When people have a serious illness, questions often come to mind because they're facing for the first time often the fact that life is finite, their bodies are imperfect, and they don't really know what's going to happen. So this raises for many people questions such as, what can I reasonably hope for? What's going to happen to me? What's going to happen to my family? Have I lived a good life? What is a good life? What does my life amount to? Is there any purpose to life? Where do I fit in the overall scheme of things? These are questions that traditionally have been considered spiritual, and in the past at least were addressed largely by religious faith and religious communities. Now, doctors may feel that we don't have any particular expertise in addressing spiritual questions, and since we don't really in the modern world have any partnership with others who do have that sort of expertise, doctors may be inclined to ignore those sorts of questions. But even though they ignore the questions, it doesn't mean that patients don't have them. And having those questions, and having those questions unaddressed, may have some influence on the quality of the doctor-patient relationship, and may form the subtext of what happens at a particular doctor-patient visit. So that was the project that my colleagues and I set out to undertake, to carefully define what spiritual needs are, to see how those spiritual needs were represented in different patient groups, and to try to determine whether those needs correlated with any measurable outcomes of patient care. I practice in Brooklyn, New York. So Brooklyn, as I think many people appreciate, is a highly multicultural borough. For many people, many people in Brooklyn are recent immigrants. You'd be surprised at how many people in the United States actually trace their origins to Brooklyn. So it's a setting in which it's very possible to do multicultural analysis without having to leave home. So we conducted this study at 4 different outpatient hem-onc sites in Brooklyn. It was a convenient sample, which means that we looked at the patient logs at each site. We then approached the patients and asked if they would participate. They had to be over 18. They had to speak either English, Russian, Chinese, or Spanish, because we originally validated our survey instrument in English, then we translated it into those 3 languages, Chinese, Spanish, and Russian, and validated those translated instruments in each of those languages. Overall, our survey had 23 items. Again, 5 psychosocial, 13 spiritual, which was the primary purpose of the study, and 5 religious needs. What we found is, not surprisingly, in an oncology patient population, spiritual needs are very common. So almost 80% of our patients reported at least one spiritual need. By that I mean they answered somewhat or very much to at least one of the 13 spiritual needs questions. Similarly, roughly 80% of patients had at least one psychosocial need. A lower percentage reported religious needs, roughly 50%. The types of spiritual needs we found was that almost 60% of patients wanted help finding hope. Over 50% wanted help with their relationship with God as something beyond themselves. So those were the types of spiritual needs we found. We found that roughly half our patients would feel comfortable having a physician ask them about their religious beliefs or their spiritual needs, roughly half. Roughly half wouldn't. We found that it's uncommon for either staff, such as nurses or other staff in the hem-onc practice, or the physician to inquire about spiritual needs or religious beliefs. So roughly, patients reported about 17% of the time staff asked about their religious beliefs or spiritual needs. Roughly 3% of time a physician inquired. We had a very highly multicultural mix of patients. Just as far as religions are concerned, we had 7% Buddhists. That's pretty high for the United States. We had 15% Chinese-speaking patients. We had 32% Catholic, which is higher than the United States overall. United States overall, more like 25%, I believe. We had 20% Jewish patients, which is higher than the United States overall. And we had 7% Eastern Orthodox, because we have a large Russian Eastern Orthodox population in Brooklyn. And then roughly 25% of the patients were Protestant, which is slightly lower than the US population as a whole. Then we looked to see, well, did it differ among the different groups? Well, all groups reported a high degree of spiritual needs. So one question we had, well, what about in Eastern populations? Well, the Buddhist patients, the Chinese-speaking patients, they had the same degree of spiritual needs as the others. There was two groups that reported a lower degree of spiritual needs. Okay? In the language group, we had four languages, you recall, English, Chinese, Spanish, and Russian. Russian-speaking patients reported a lower degree of spiritual needs. They had a lower spiritual needs score on our scale. And among the religious groups, Jewish patients and Eastern Orthodox patients reported a lower degree of spiritual needs. Now, there was one other key finding. We did a univariate analysis to see whether or not there was any correlation between patient satisfaction with care and the perception of quality of care and their spiritual needs. If they had a higher spiritual needs score, if they had a higher religious needs score, or if they had a higher psychosocial needs score, on a univariate analysis, their perception of quality of care was lower and their satisfaction with care was lower. So having a higher level of any of those needs in the univariate analysis correlated with a lower perception of quality of care and lower satisfaction with care. However, we then did a multivariate analysis. We did a multivariate analysis. The psychosocial needs and religious needs dropped out. That the higher spiritual needs correlated significantly with low perception of quality of care and less satisfaction with care, but the religious needs and the psychosocial needs no longer predicted. That was an interesting finding. Additional training for physicians and nurses and how to acknowledge, elicit, and support patients' spiritual needs may be one way to improve patient satisfaction with care and the perception of quality of care. The second message is that these are sensitive issues and our interventions may need to account for differences between cultural groups.